go ahead and call it. I'm calling us to order here. This is the behavioral health meeting of the Incarceration and Prevention Task Force. And we have a land acknowledgement statement I'd like to read. Before we begin, we acknowledge that we're gathered on the traditional and unceded territory of the Lemhi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. Okay, thank you. Let me just go ahead and expand the screen here. Give me just a moment. Oops. Okay, wow, we've got quite a lot of people here. So what I'm going to do here is I'm just going to go through and call on people to introduce themselves and who they're affiliated with. I'll start with Peter Frazier.
Thanks, Dan. Peter Frazier. I'm a local business person and citizen. I am here affiliated with the IPRTF.
Okay. And I'm just going to go right through the gallery, including myself. I'm the next one in my view here. I'm Dan Hamlin, Bellingham City Council, and I'm the co-chair of the Behavioral Health Committee. And then I'd like to call on Rob Sullivan.
Thanks, Dan. Rob Sullivan, Regional Director for Pioneer Human Services.
Thank you, Rob. Letitia?
Hi, good morning. I'm Letitia Nunez, and I have here with me Judge Lev, and we are with the Bellingham Municipal Court.
Good morning. I'm Deborah Lev, Judge of Bellingham Municipal Court. Thank you for inviting me here today.
Welcome to both of you. Renee?
Hi, everyone. I'm Renee. I am the clinical nurse manager for the Crisis Triage Center. I'm really excited to be here today, kind of listen to everybody's ideas and get some input. So thank you.
Welcome. Perry?
Good morning, folks. I work with the Response Systems Division as a behavioral health supervisor, work with a number of contracts, and also act as a liaison between the county and the providers at the Ann Deacon Center for Hope Crisis Stabilization Center.
Thank you, sir. Undersheriff Harris.
Hi, I'm Steve Harris. I'm the Undersheriff of the Whatcom County Sheriff's Office.
Mike Parker.
Good morning, Mike Parker, work at Opportunity Council, and I'm honored to co-chair the Behavioral Subcommittee with Dan Hamlin.
Dr. Bousted.
Yeah, hello, I'm Shannon Boasted. I work at CMAR. I'm the opioid lead physician for CMAR's opioid response throughout the state of Washington, and I'm a local provider of MAT services at CMAR.
Amy?
I'm Amy Pereira. I'm the Director of Crisis Response and Stabilization for Compass Health.
Officer Surratt.
Yeah, Officer Zach Surratt. I was previously the department's behavioral health officer.
Stephen?
Directly member of this committee.
And Clinton.
Hi, everyone. Clint Jordan, Vice President with Pioneer Human Services.
Melora?
Morning, everyone. Melora Christensen, Response Systems Manager for Health and Community Services.
And Arlene?
Yes, well, I represent behavioral health, and I'm a marriage and family counselor with more than 40 years experience. And I currently work for Touchstone up in Blaine, teaching interns.
Thanks, Arlene. Chief Mertzig.
Hi, I'm Rebecca Mertzig, Chief of Police for the City of Bellingham.
Prosecutor Ritchie.
Eric Ritchie, Whatcom County Prosecutor.
Chief Rickman.
Scott Rickman, Division Chief, Emergency Medical Services, Bellingham Fire Department.
Jill Nixon.
Good morning, Jill Nixon, Whatcom County Council Office and staff for the Incarceration Prevention and Reduction Task Force.
And Courtney. Courtney may have stepped away. Mike Hilly.
Yeah, apologize. Thanks. I was in the guest mode apparently on the webinar. Mike Hilly, Emergency Medical Services Manager, and good morning.
Good morning. Hey, Courtney, go ahead. You got your hand up.
Hey, is my mic working now?
Yeah, it is. You're good.
Okay, great. I'm Courtney Taylor, a behavioral health and mitigation specialist at the Public Defender's Office. Thanks.
Thanks, Courtney. Jill, did I miss anybody?
I think that's everyone.
Okay. So thank you everyone for being here this morning. As you can see, we've got a range of professions and individuals here representing a number of organizations and governmental units and bodies. And so I want to get this discussion moving. We've got a lot of ground to cover. It's 9:09 right now. And I've asked Peter Frazier to facilitate the discussion here on the Ann Deacon Center for Hope. And so we can move forward. I'm going to turn the reins over to Mr. Frazier.
Thank you, Dan, and thank you for everybody who's attending this meeting. I very much appreciate it. I was asked to make a presentation today and was prepared to interview key informants around the Crisis Stabilization Center and then do a report. However, in talking with Melora, it just sounded like a better alternative to bring you all together for a discussion. So that's what we're going to do today. To my mind, there appears to be a difference between what policymakers, citizens, law enforcement, EMS were expecting how the Crisis Stabilization Center would roll out and work. And one hears things about various frustrations and barriers to service delivery. So I thought it would be a good idea to have a full discussion in the time that we have around some of these issues. And the whole idea, the whole purpose here is to listen to one another, understand what the barriers and challenges are, and to look for solutions together. And that's not all going to happen today, obviously, but it seemed like it was time for a meeting of this sort, because service delivery to individuals who are suffering and in crisis is what our job is here. And we have planning coming up for a 23-hour crisis relief center, a $16 million facility. It should be finished in 2026 if everything works well. These two operations need to work well together to serve our community. And so I want to make sure that that in that planning process, we're looking at the Crisis Stabilization Center as a model and how these things are going to dovetail. So I thought that we could spend the first 20 minutes hearing from law enforcement, EMS, and then the next 20 minutes, perhaps we can hear from the folks at Pioneer and Compass and the health department, and then take the rest of the time for questions and discussion. And Dan, I have a report on the implementation plan. I think I can just do a summary in the last 10 minutes. And Jill has sent out that report already. And so that is a minor thing today. I want to take as much time for this discussion as possible. So again, we're looking for fresh understandings so we can maximize service delivery. And let's begin with let's begin with law enforcement and EMS. And I see Officer Sarad in front of me here. So would you like to begin? And I ask each person to do your level best to keep it short and sweet. What sort of challenges have you been experiencing? What sort of wins do we have? And those sorts of thoughts for us.
Yeah, good morning. I can keep it short and sweet for you. It's great to see so many old faces. I'm no longer the behavioral health. Hello, Melora. I'm no longer the behavioral health officer. I did it for several years, and due to staffing, we had to unfortunately conclude the program. Laura Woods, who was with the Grace team, was my partner for many years. So if I drop Laura's name, it's because she was with me throughout the entirety of my time as a behavioral health officer. I was fortunate enough to, I don't remember all the committees and meetings I was on, but I was fortunate enough to be in several meetings leading up to the opening of the crisis center. I have talked to patrol, and although I'm not the BHO anymore, it's probably not a day that goes by where someone doesn't call from the department or an organization out in the community. So I'm still, maybe not by title, I'm still the BHO, I guess, if you will. So when I learned about this meeting, I reached out to patrol. I have a plethora of notes, but I'll keep it brief. I think the main takeaway that you're going to get from patrol is that the facility is not an involuntary facility. I remember the moment that Laura and I learned that the facility was not involuntary. It was quite a disappointment, and I know the difficulty. I don't understand it, but I acknowledge the difficulty of having a facility that is involuntary. There's insurance issues, there's employee issues, there's a lot that goes along with it. But for several months, we had assumed that it was going to be involuntary, and unfortunately, that was not the case. And since its opening, that's kind of been the ongoing issue. A couple key takeaways from patrol. Please keep in mind that myself, you're not going to find any other officer who has more respect and understanding of what the behavioral health organizations do in the community, along with what's happening at the Ann Deacon Center. As the chief knows, you can never make a room full of police officers happy. We're never going to agree on anything. So these are just opinions. Some are very educated and some are just some grumpy police officers. With that said, a few of the top ones I got was, and I agree with this, the center does not deal with the crisis that police deal with. We are dealing with people. Basically, the word crisis is defined differently from what the center deals with to what police deal with. I'll come back to that, but we've had several poor interactions with staff members there. I would argue that that goes both ways between police and the staff, but that's one complaint that I've heard. We have people in the community treating the center like a hotel. I will agree with that one, and meaning that there's repeat people that stay there. They will come to the station even and ask for a ride there, knowing that they'll be taken in. They're not under a crisis. They're not from what we define as a crisis. And, it's been called the second Motel 6 in the city. And most of us refuse to take people there unless they can articulate some sort of crisis. A longer process than the hospital. Unfortunately, the center opened up like right before COVID or during COVID. So there's a process there. If you don't have to write an affidavit to have somebody held, the hospital is far quicker than the center. And when you're talking about staffing issues for patrol, when you're talking about having 2 patrol cars heading up north to wait for whatever process is done medically, not including the time that we take to call the center and get the person approved, it's much longer than the hospital. Additionally, and I believe this was taken care of, for a long time, we had an issue of the center calling us back for transports from the center to any location in town when they refuse somebody. I believe that was taken care of though, but that was a big complaint from officers. The hospital never calls us back. They would just let people go. But for a while we were doing transports. And for me and a few officers and it says on the website too, that the Incarceration Prevention Reduction Task Force, they want to reduce the amount of people, the amount of time that we're incarcerating people. But I have found during my time as back on patrol now, and a little bit at the end as BHO, there were times that I knew the center wouldn't take somebody that was going through what we deemed to be a crisis. I knew there was no chance of it. And so we, if you guys are not aware, we cannot book anyone into our jail unless it meets certain stipulations, usually a felony crime or something. But a lot of our folks that have behavioral health issues are walking around with up to a dozen misdemeanor warrants. So our department set up a private jail called SCORE down south, about a 2-hour drive with good traffic. I was making the decision, instead of going to the center, knowing that it would just be a headache, we were calling in officers on overtime to transport people all the way down to SCORE instead of driving them up to the Ann Deacon Center. So if that, and that was a decision I made several times. The main takeaway is, without it being an involuntary facility, the people that we're dealing with on a day-by-day basis that are the highest utilizers of 911, with a few exceptions, with the highest utilizers of 911, it's just a drop-off for us, a drop-off that takes more time, that we have to. Another complaint is it's a crisis center, except when someone is deemed to be enough for what we call an ITA, an Involuntary Treatment Act, we are called back there to take them to the hospital. It's just, some of the stuff doesn't make too much sense, but I can say overall, patrol is not happy with it. I'm not sure what the numbers are currently of how many people we do take there. I'll be honest, I don't utilize the facility much anymore. I took someone up there the other day, a couple of weeks back, and he had just been there the night before, I believe. And they accepted him. So, double checking my notes here. So yeah, I think that's enough said on the police side. Basically, we need an involuntary facility. We were excited for the facility to open so we can quit utilizing the hospital and give those folks a break. But I think we are back to probably what we were before the hospital. I'm not sure what officers do utilize the facility very often. Maybe night shift is doing it more than I'm aware of. I'm on days now, but that's kind of where we stand as a police department.
Okay, thank you for that concise update. I really appreciate it, Officer Rod. Let's move to Chief Rickman and get an EMS perspective.
I'll echo what Zach said. I'm responsible for community paramedicine or mobile integrated health. And we've been doing this since about 2013. And we've been waiting for a place where we could take people and divert from the hospital. I'm going to start with a quick story of my own experience with the center that was, I guess, extremely disappointing. We had a 45-year-old male who had overdosed the previous day. Laura knows the story because I called very upset. Our crews went out the next morning to, for lack of a better term, like a halfway house, an unofficial halfway house. We had called the center, secured a bed. I drove them up in my chief's vehicle. Went to the front door. They were audibly annoyed that I rang the front doorbell. It was my first time there. They told us to go around the back. It's 40 degrees and pouring down rain. This is somebody who wants help. We were left at the back door for 10 minutes, not let into the back room that's clearly meant to be a receiving area that's warm and dry. I was met by 2 people at the door who opened the door about this far and stuck their head out, did not see me standing there, and were refusing to let this individual in until I said, I'm with the fire department. We just called you. We have this person that you agreed to take in. Well, he doesn't have his medications. I said, he was released from the hospital yesterday. You got the full story on the phone. Now we're refusing it. So I opened the door and walked in and would not leave until your folks took him to the back of that facility. The trauma that was caused additionally to that individual, just in this story alone, is just, it's very disappointing, I guess. So I guess what we've seen is exactly what Zach has said. We've had issues with what staff's comfortable taking. I think there was a higher expectation from everybody that's response, that's actually bringing in, I would say, the highest utilizers, the most vulnerable populations, that there would be lower barriers to the center. I think there's a lot of frustration in the community that when we're hearing 60 and 70% census rates during the day, that it's a concern as a taxpayer and as a service provider that we have beds available that we can't utilize. And I really do, I agree with Zach. I mean, our thought was that we'd be able to bring these folks that did just overdose, the people that are needing to be sedated and do some other things, and have appropriate medical management of those people on site and not have to divert through the hospital. And I can unequivocally say that I have responded more and transported more from the diversion center to the hospital than we have taken to the diversion center. So I think that there's just a lot of confusion around this. There's a lot of frustration. There's tons of friction between the staff in first response agencies and the staff up there. I won't begrudge that. I think it's just reality. And I think there's a lot of fixing to do to make this effective. And it's disappointing because we're at a 3.5 overdoses a day. We had 6 yesterday. Just yesterday that we brought back, 3 of which had CPR. These folks that we're bringing up with Narcan and everything else on the street, we should have a place to take them. That was the intent, was my understanding of this facility. So I've been talking about this. Councilmember Hamill knows I have a huge amount of frustration with what's going on. My responders have a huge amount of frustration. We want something that works. And I think that's what the intent is to have something that works so we don't keep killing people on the street.
Great. Chief Rickman?
Yeah. To nail it down and to be just bluntly honest, there's zero trust between my responders and the diversion center. There's zero confidence that we can take everybody there. And so I think that's where we have the work to do and to figure out how to make this go better.
Very good. Thank you for that report. I really appreciate that. Under Sheriff Harris, would you like to speak for the Sheriff's Department, or do you have somebody else you'd like to take this?
I think I'm the only one here, and I can tell you to go along with what's already been said is we understand Bellingham's need, and the last thing that we want to do is transport somebody from the Kendall area or in a very rural location into the city of Bellingham only to be refused service. There's a couple situations that occurred. I can tell you we had a good, robust discussion last week with Perry in the Crisis Stabilization Facility Committee meeting. There's probably materials that I would encourage folks to look out for. But yeah, as far as alternatives to arrest and the 12-hour hold, I know that Compass Health advertises as a 12-hour hold facility, but they can't hold anybody. It's voluntary. So there is a little bit of frustration on that. We still want to move forward with this model. We hope we can get better results. I know that now that we have both of our behavioral health deputies and our co-responder program is working, I think that there will be more drop-offs to the facility, at least during those hours. But, as Zach said, a lot of the clients that we deal with, none of these things have worked. That's why law enforcement is being called by family anyway. So, having a 23-hour hold facility or somewhere else that there's a little bit more mandates who we can drop off, I see law enforcement diverting mostly to the hospital, especially if we're driving from a very rural area. We know that they're going to be taken there.
Very good. Thank you. Is there anyone else from law enforcement, EMS, that would like to express anything?
Chief's got her hand up.
Great. Chief, go ahead.
I'll be very, very fast. What I asked Zach to do, and what I'm glad that Scott did as well, is speak the truth in love, is what I told him to do. They are the most compassionate people in the city, and that's why they are so impassioned about what they're talking about, because it is we feel a broken system. So I just want to put that out there. And it's hard to hear sometimes, but it is the truth. So I just wanted to relay back to Zach. I think he had his hand up real quick for one more final comment from us.
Yes, Zach.
Yeah. Sorry about the late reply there. The sheriff reminded me and Scott reminded me. The patrol wanted me to add that I wish Kellyanne from Base Camp was on there. Base Camp has been phenomenal for us. I will call Base Camp before I will even call the Crisis Center, because they step up and are willing to take people on that I don't think the Crisis Center will. So keep that in mind. Base Camp is leaving downtown, heading back towards F Street here in a few months. And they've been phenomenal, which absolutely should not be the case at all. That's not what Base Camp is there for, but they have been fantastic. If that says anything right now regarding the current situation. Thank you.
Very good. Courtney, did you want to add something at this point?
Yeah, I'm not law enforcement. I'm kind of in between these worlds and mitigation. So I'm not a treatment provider, but I was one. And I'm not law enforcement. But I just really wanted to highlight what officer, where did he go on the screen? The officer that was just speaking. I can't remember his last name right now, but Sarad.
Officer Sarad.
Yeah, Officer Sarad. What he just said about base camp, I mean, that as an MHP, that disturbs me. Why are we relying on base camp more than crisis triage when they are meant to have the staff on site to respond to situations that base camp is not trained to respond to? That is concerning to me. And there's a lot of things I could echo that law enforcement just said. There's some things that I want to push back on, but I want to hear from the treatment providers first, because I'm kind of in both lanes. Yeah.
Thank you so much for your perspective, Courtney. And Eric, Richie, I see you on the call. Is there anything that prosecutor's office would like to say at this point before we move on to the providers and the health department?
Thanks, Peter. I'll wait until there are questions.
That's great. Okay. Well, I appreciate hearing from everyone, and looking forward to hearing from our friends and partners in service, who are the service providers. And
Peter,
yes,
you've got Arlene Feld's hand up over here.
Well, he wanted to hear from the service providers at the next section, but I'll go ahead and say this, that I worked for crisis triage for 9 years before it was Ann Deacon Center. And the same problem existed then. So it has been throughout the history of this, and it's not intended for any kind of security, because there isn't any, so we have to have a place that addresses the source of all our problems, which are social problems and emotional problems. And that is very expensive. It will cost a lot of money, but it will be worth doing. And I thank you very much for the report, Peter, because it was, even though I just had time to glance at it, it was very, very good report.
well, thank you, Arlene. Let's move to Melora. Melora, would you like to kind of set the ground for this next section?
Sure, I'm happy to do that, but I saw Dr. Bosted's hand go up. Shannon, did you want to say something?
Please go ahead.
Okay. Yeah, I appreciate this conversation. I know that there have been many conversations like this over the years prior to the Crisis Stabilization Center opening. Of course, these conversations have happened in the last couple of years since it opened. And I think the things that I just want to highlight is there are a lot of efforts being made to address these issues. And I hear Officer Strad, Scott, I hear you. I know it. My teams struggle at times to utilize the facility as well. And I think that I want to couch that with the other dilemma that we have in this community, which is supporting our provider community to have what they need to meet the need. And so we sometimes don't have the emergency room that we need for our clients. We sometimes don't have the stabilization. We certainly don't have an involuntary facility. And I think it's really tragic that first responders, especially our first responder leaders, weren't aware that this was not going to be involuntary facility. And so I'm reflecting a lot on that, and like, where was the communication breakdown in which we had expectations in the community that's, you know, and I'll let the providers speak to their state licensure and what they're able to do in that facility. But I think for us to really recognize that we really need to understand the nuances, which Peter, I appreciate you digging into this, because I think that's why we're here. So I also want to recognize that, and I think Compass and Pioneer will speak to this, that there have been really great collaborative conversations about where we can improve. And so I'm hoping that the providers can speak to those things that are already happening. And I would say from Health and Community Services, and the county holding the lease for this facility, our hope is that within the next 1 to 2 years, this group would get together and talk about how this facility is appropriately meeting the need of what they're licensed to do, right? That we could move this narrative to it's meeting the need that they can actually respond to. And then if the facility is not able to do that, then what else in the community are we willing to do? So I'll leave it there. And I think folks are going to have a lot of tangible items to share today.
Thank you, Melora. I really appreciate your setting the ground there. So let's hear from someone from Pioneer. Who would like to speak first? Since I can't see people raise their hands for some reason, I'd just appreciate if you would go ahead from Pioneer.
Sure, I can start. And again, I'm Clint. I'm the vice president with Pioneer. So not only do I have oversight of this program up in Whatcom County, but also our other crisis stabilization work across the state. And so I guess I would start with, my perspective is informed by, both what I see working well in different regions, but I also have a sense of some differences. And so before I get into some of that, I would just start with just recognizing the feedback that's been given today. I appreciate that. In unpacking that, we can get into the different nuances, but I think just first and foremost, the feedback is the feedback. And it is important for us to be meeting the community need, and we recognize that. And we are committed to moving things in that direction. And so I just want to make sure that's clear. Rob's with me as well. I know he can speak to some of the sort of specifics within the facility probably better than I can. But I just want to say that on behalf of us, that we hear that. So Rob, I don't know if there's anything you want to add.
Sure, I would echo what you said, Clint, about the feedback, and I agree with Chief Mertzig. It's not always fun or easy to hear, but I certainly have made it a priority in my life to give me that feedback because I think that's how we improve. So that's kind of where we started from. And I don't know if we want to go into specifics at this moment of what we can or can't do, or am I jumping the gun?
Let's roll through. Let's just roll through right now, and not with solutions, but just hearing each other around barriers and challenges that you have, and then we can head towards solutions.
Okay.
So anything else you'd like to say?
No, thank you.
Certainly got the time to do so. Okay. Let's see. So we've heard from two folks from Pioneer, and we have someone from Compass Health, Renee.
Yeah, I can go ahead and speak to some of this, and I'll let Amy speak to others.
Thank you.
Yeah, I do really appreciate the honest and true feedback. It's not the first time that I'm hearing it, unfortunately. Being new to Compass, I've kind of come in and am hoping to make some of these changes that obviously the community is needing at this time, and have needed for a little bit. So my goal is to listen and kind of learn and then implement in ways that are going to be positive for everybody involved, for us and for you guys as well. I believe I met Officer Sarad when he did drop somebody off, and that was a pleasant drop-off experience and stuff. But there was a few things that I wanted to address based on what you guys were saying, so I could kind of let you know what's going on our end of things. And you can kind of hear my heart in all of this with the community, because I have a big passion the same way all of you guys do. So one of the things I heard you guys say is that the intake piece was too long. And that's a common thing that I am hearing. So just so you're aware, we are in the process. We have dropped the COVID protocol, which automatically takes 15 minutes off of intake, and we'll only be testing if there's signs or symptoms of that. So that is no longer a requirement when someone walks in our door. Another thing is the intake call form. We do have a shortened version. I am not sure what version they're using for you guys when you call in, but I'm going to follow up on that. Because it should be fairly short with very quick answers to be able to give a yes or no answer for possible admission into triage. So I'm going to follow up on that piece and see which one you guys have been using with our intake staff. And also I've done an all staff meeting, and we've also met with Jessie. She's our quality director, and we're trying to find a way to shorten our intake process from beginning to end. It can last 2 to 3 hours with all the questions that we have to do. And some of that is legal requirements that we have to do that unfortunately we can't get away from. However, there's no need for you guys to be here for that entire process, which I'm hearing is a big problem. So some of that will be changing as far as the length of time and being able to assess how the client is feeling when they walk in our doors and how much we can actually get done at that point or hold off for later. So those are the kind of ideas that are floating around. And Amy can correct me if I'm wrong, as she's the director over me, but having you guys not able to drop off voluntarily crisis patients and having to stay isn't necessary. You guys should not be having to stay. With that, there is the concern, and this happened last week, I think, with another community partner. If someone isn't medically cleared before someone who brought them in leaves, it puts a lot of pressure on us to get them back out the door. I know it was mentioned the hospital just kind of opens the door, but a lot of reasons we can't accept a client is because they're medically not stable. That could be a blood pressure that's 200 over, 120. And to just let them out the door isn't a viable option for us. So at that point, we either have to call Cascadia or EMS 911, which then, it bogs down that system also. Whereas if there was someone here to be like, hey, can you take them to the hospital? That would be beneficial for us. But it's not necessarily your job. So I think finding a solution with all of that would be really beneficial for our side and for your guys' side. We have started using the art team a little bit. Colin over there does some transportation, and he's been great. But if we had more resources like that, that would be wonderful. It would take the stress off of us and kind of relieve you guys and being able to just do a drop off for crisis triage. So the issues with the front door, not okay. And my staff have been told as of a week ago that if someone rings the front door, they're going to go to the front door and get the client. They're not going to ask them to walk around to the back. The back has been the entrance because of COVID, is my understanding. So either option is completely fine. No one should ever be standing out in the cold, in the rain, in the snow. I have also told my employees that that is not to happen either. So if you guys come to the front door, we'll be answering the front door. If you guys come to the back door and are not let in, call right back, because that's not acceptable practice for me or my staff. So that's a work in progress, because it's kind of just been what's the norm. So anyway, I just wanted to address that and just kind of get on your side with that should not be happening, and it won't be happening. The other thing I wanted to address really quickly is the medications, because it sounds like there was somebody, Scott Reichman mentioned that he had a patient come in and we didn't allow him because of medication. So I did want to address that really quickly because that is an important piece of triage process. The way you were treated and the 10 minutes outside, not okay. The medication piece is a little bit more of a difficulty for us. The problem becomes if they don't come with their medication, it's very difficult to track it down. And then we have no access, quick access to the medications that they need. So if they're on blood pressure medication, heart medication, whatever it is, if they don't come with it, we either have to order it and then we have to figure out if they have insurance, don't have insurance. We have to rely on a family member to bring it in, which half the time doesn't happen, even if they say that they'll bring it. Or we're depending on the hospital to be able to bring those medications. And that usually happens, but it's more of a process. So I just wanted, in fairness to crisis triage, having those medications in hand when a patient comes is really important to us, and it helps speed up the admission process for our team. And it's better for the client. Now, if that can't happen, there are things that we can do. It just takes longer to get them started on that medication. So I just wanted to give kind of the insight to the medical piece of that.
Thank you, Renee. That's terrific and very helpful, I'm sure, to everybody on the call. Amy, did you want to speak to anything from Compass perspective?
You might be muted, Amy. I can't hear you.
Sorry, my audio cut out, and so I had to do that. I'm on my phone, and sorry, double mute. So if Renee,
we can hear you now.
You want me to address, let me know. But the medication piece we are internally working on with our chief medical officer as well, to see about getting either more meds on site so we don't have that delay of getting to the pharmacy, or other options, because the other challenges, nights, weekends, holidays, we really struggle when the pharmacies are closed to get medications in, which once again is not a problem for anybody here, but something internally that we're very mindful of and trying to figure out a solution to.
Amy, thank you for that. I'd like to circle back to the two gentlemen from Pioneer in case you want to go down to the next level that Renee and Amy just went to. We
Sure.
have
I'd be happy to. It's Rob.
Six more minutes until we go to questions.
So Rob Sullivan again, similar to Renee, and I think we got the 5 questions originally from Compass, is that we had all agreed a long time ago to, if law enforcement or community paramedics are dropping somebody off, that they're going to call, ask if we have a bed, and then there's 5 questions. And I don't have them in front of me right at the moment, but there were basic questions, and law enforcement and community paramedics were supposed to show up, drop the person off, and leave. It sounds like some of that is not happening. Certainly that's been the direction that I've told staff to go to, and the direction that we look at when we want, I certainly get that there are other things you're doing besides dropping people off here. And we want to get you in, get you out, and get you back on the road. And so it doesn't sound like that's been happening as consistently as we wanted to. Medications are not as much of a challenge for us. I think where we run into problems sporadically is around diabetes medications. But I think that's been less of a challenge for us than it has been for Compass. And we had a meeting about a month ago to talk about some of those challenges and look for ways that we can get around those. So that would be my piece.
Thank you so much, Rob. I really appreciate. I'm feeling a sense of people looking for solutions, which is exactly what we're wanting to. We want to hear things, and we want to look for solutions. And where there are barriers, let's understand them and move through them. Mike, I was going to go to Clinton first, see if he had anything more to say, and then we can start the rest of the discussion. Clinton, is there anything else you would like to say?
Yeah, just a couple things. One I heard come through often is just the customer service side of things. And I think that that's a very controllable area, and one that, through past examples that have come up, through what we've heard today, I just hate hearing those things, and there's just a commitment from us to make sure that that's something that does improve. You know, there are going to be challenges through this, but that should not be one of them. And so when I hear of people out in the cold, people not getting access for extended periods of time, the front door issues, all of that is so fixable, and quite frankly, actively underway and being fixed. And so hopefully you'll see the results of that soon if you haven't already. And then there was kind of earlier reference to was a kind of just, I think, what a bigger, more complex issue around ITA and around the utilization of the beds in the program. And that's going to take a lot more work, right? And I think one thing that's important to note is that that at least on the withdrawal management side, even through a lot of the challenges with COVID and how that impacted utilization still exceeded 75% to almost 80% of the beds, which is, you know, for a 16 bed, that's, you know, you're looking at 13 beds generally full all the time, which means often that's max capacity to have an average like that. And so while I think what we do see in terms of differences is that a lot of the referral sources, as were noted here, are not coming from law enforcement and first responders, but there's still this significant need out there for these services. And so I just think as we talk about who it's working for and who it's not working for, it's kind of important to point out that it is working for a lot of people, and yet maybe the sort of target referral source, which is law enforcement and first responder systems, and that maybe we're missing the mark there. But I guess I say that to say that as we hopefully shift and improve that collaboration, that there will still be others who are not able to access services that they desperately need. And so I just think that context is really important.
I think you're right. That is good context. And let's see, I know Mike Parker and Dr. Bosted, and then Courtney.
This isn't really a question. It's more of a clarification. I think, Melora, you started us down this path a little bit with talking about what the facility is licensed to do. And I know we've talked about that a little bit, and I've heard both from Pioneer and from Compass a little bit about that. Could somebody volunteer from one of those two organizations or both, in a nutshell, just for the record, just tell us, what are you licensed to do? And I think that might help, because I'm still hearing confusion years after the fact. And I think it might be helpful to actually spell it out and say, we're licensed to do this. And then if you've heard the feedback about what they wanted it to be, we're actually not licensed to do that, because I think that would be helpful.
Sure, I'll go for Pioneer. So Pioneer's licensed as a residential treatment facility, providing acute withdrawal management services. So there's some limitations around that. We can't have people with oxygen. People have to be voluntary, meaning they're willing to come. I think, as Officer Suraj said, there's some truth to that. We do get people who are frequent attendees to our facility. And people have to be able to do activities of daily.
Rob, you went back on mute.
You muted yourself.
I muted myself. Yeah, I just realized that. Sorry about that. Thanks, Mike. People have to be able to do their activities of daily living, meaning hygiene and etc. And they need to be willing, and on some level, to be in services. Certainly, we get people who come in and leave just as quickly as they came. And there's certainly, as Renee indicated earlier, you know, we do get people who start to have significant medical problems because they're not connected with medical services. And they're just beyond our level of care. We just can't keep them safe.
Thank you for that. And Amy or Renee, would you like to speak to licensure?
Yeah, I can speak for Compass Health. So we're the same. We're licensed as a residential treatment facility and licensed to do voluntary mental health services for clients who are there. So it's really similar. It's crisis stabilization. So, or the inpatient residential, so 3 to 5 days overnight they can stay there. We can only do mental health, so we can't prescribe other medications. Only things that fall under like the mental health scope. However, we can, if someone already has a prescription, assist with the ongoing of receiving the meds. But it's the same type of services. So it is just voluntary mental health that we are licensed to do.
Very good. Thank you so much for that. And Dr. Bosted, I don't see your hand down, but I thought I saw it go up. Did you want to say something?
Yeah, I do. I'd like to just provide a little bit of context, and then I have a couple of solutions, or at least, recommendations that I'd like to offer. So
Yes.
I'm a family doctor. I've been working with patients with opioid use disorder for the last 17 years as part of my practice. I've worked in the Bellingham area for 12 years as a family doctor at CMAR. And between those two roles, I can tell you that I've seen all the times that people kind of like the end result of all of these efforts and things that we're doing in this arena, in all of the first responders who are doing such really deeply important work. I've been to detox. I see the hard work that's happening there as well. And then I see people who come to see me, and there's multiple levels at which I engage with people. So I was working as a primary care doctor, so people coming out of hospitalization or jail or detox in varying degrees of chaos because of essentially they're not able to coordinate their care, and no one else has the opportunity to reach past their own focus of responsibility to facilitate that. So I it feels a little bit like picking up some of the pieces that are left through no one's fault on this call. I really think that's important. We are all on the same page. How do we get to a better outcome? I can tell you that I work in the medication assisted treatment. We provide medication for opioid use disorder. I've seen people really transform their lives. I get to see the end result of where people are. I see people who've been through detox or inpatient. Yesterday, I talked to someone who'd been through 18 times, and for a variety of reasons that they weren't ready to engage, or I think one of the larger issues that people, once they are ready to engage, they go through this process, they get through all the hurdles, they've gone through inpatient, they're doing well. Then what happens after that? They still are facing the same kinds of social problems. They don't have any of the support. They may have unmet medical needs. They may have unmet psychiatric needs, and it just drops off. In the last month, I've had multiple referrals of patients who are unhoused, who have been to detox, but then due to weather and things, they were unable to engage with ongoing services, and they relapsed. And then they're coming to me after a relapse, after they'd already been stabilized on the medication, which is a challenging, and it feels like an unforced error that as a society that we can really do something better about. I also have been for the last couple of months going to base camp and providing, kind of urgent care services over there weekly. So I also there am seeing, these patients who over time are developing very significant behavioral health and medical conditions related in large part to ongoing substance use, unmet medical needs, lack of housing, and what I see is that people kind of over time, they go from the point where their primary issue is substance use or behavioral health. And so that's how the rest of these service teams are engaging with them, to a point where it's all degraded to the point where it's so severe that with our current models, we can't meet those needs of those who really are in the greatest need. And I mean, I can tell you that Basecamp does an amazing job, and they are totally overwhelmed. It is a travesty that they are where people end up. It's one of the saddest parts of my day, seeing how much society, again, through no fault of ours here on this call, but our society fails those who need the most help, and they end up at Basecamp. So all of that said, like I say, I've been seeing multiple sides of this through all the different parts of my practice here in our community, and I have a couple of thoughts about things that we can do and things that I've seen to be effective. One of those
I would love to. would hold those things for right now, and
Okay.
I want to cycle through the folks that have their hands up. If we can get back to you, we will, and otherwise, I really want to hear what those things are. Okay, but Dan, would you? Oh no, Courtney, go ahead.
Um, we never have enough time together to
Of
get all of
course.
our thoughts out.
Yep.
I appreciate what Shannon's speaking about. And yeah, base camp is totally overwhelmed. And like Officer Surratt said earlier, they are not mental health providers. That's not what they're there to do. I think ultimately what I'm hearing from this meeting and so many before this one is, I do mitigation. I see themes and patterns. The recurring theme that I hear over and over again is that we are talking about complex human issues that are abstract shaped pegs that we are trying to fit into very square holes. And what we are talking about right now is metrics-based systems that do not align with human behavior and the nature of recovery. Recovery is not linear. Recovery is not black and white. It is not going to fit into the mold of the time-sensitive models that all of our systems are structured around, whether it's EMS, law enforcement, or managed care through the nonprofit system. From the perspective of a client who is navigating these systems, our clients at the public defender's office, I can say that it's been a mixed bag. We've had some folks that have had very positive experiences with crisis triage. They really helped us out, saved our butts, got meds, just went above and beyond. And then we've had other experiences where, very similar to what other folks are speaking about right now, that frustration. I just want all of us to remember and keep in mind that all of us have a part in this puzzle each time we get someone successfully admitted to treatment, whatever point in the system that they're getting care. Each time they get that treatment, you are reinforcing a positive experience for them in the world and replacing some of those negative experiences, not erasing it, not making it everything better, not waving a wand. There's not a single point in the system that's going to give everything that everybody needs. And that's why we're all meeting here together. But if we can all get on the same page about how complicated this is and that it is not black and white, and that maybe the way some of our gatekeepers are defining crisis is part of the problem, and the way that we are licensed is part of the problem, I think we can see a lot of different outcomes. I think we're on the right track. Yeah, I could go on. Thank you.
Great. Thank you, Courtney. I really appreciate that. And Dan, you go ahead.
Yeah. So I don't know if you guys are seeing this on your screen, but there's some kind of whiteboard that's happening. Okay, great. That just went away. So just a couple points.
Right, thanks, Dan. I'm going to interrupt for just 1 second. Yeah, if we don't allow whiteboards in our office, it's not something we can manage for Open Public Meetings Act. So if we can not do that, that would be great. Thanks.
Yeah, we are constrained with the Open Public Meetings Act, so please contain your comments to the panel in front of us here. So 2 points. One is that the ITA issue keeps coming up. That's a separate discussion. That's a huge discussion that we could take an hour and a half not getting to the end of it, and we need to have that discussion. My question for the providers, however, is I'm curious as to how co-occurring disorders, whether substance use, opiate use disorder, and mental health. So the intersection, how are those patients treated in this facility? Do they go from one side to the other? Are they treated with their mental health illness over at Pioneer, or how does that work?
So we have had people who come in primarily for a variety of behavioral health issues and have worked pretty collaboratively with Compass on getting people detoxed and then transferring them when appropriate over to their facility. I think it's an ongoing challenge because it's not, as somebody just said, it's not black and Courtney had said, it's not black and white, it's complex. And there's not a perfect answer for it. For a whole lot of reasons. So we do provide MAT, we do Suboxone, Vivitrol. We have people who come in who are connected to a methadone clinic, and they will get dosed at the methadone clinic, or the methadone clinic will send medication over. for them to get dosed for opiate use disorder.
Dan, does that answer your question?
Yes.
Good?
Yeah, thank you.
Okay. Perry, do you have a pithy comment or two?
Just really quick, Mike, I really appreciated Mr. Parker's question just in regards to, wow, understand the basics here in terms of, certification and et cetera. And the providers did a great job, in terms of responding to actually a fairly sophisticated concept in the questions. But one of the things that I also wanted to reiterate was that the certification and licensure that both Compass Health and Pioneer Human Services have at this facility, they can't go hands-on. And sometimes that really cuts down to a point for law enforcement, and other first responders of where if an individual, is in real, difficulty and challenges in terms of psychosis or significant intoxication, that sort of thing, the staff literally cannot put their hands on the individual. That is part of the licensure. And I wanted to clarify that because I think that it was a really helpful question. I have a number of other comments, but they're all solutions, Peter, so I'll stand by.
Okay, let's roll over to Scott and then Mike, and then we'll circle back towards some solutions. Obviously, that's a long conversation, but I'd like to get into it. So where'd you go?
Right here. So I guess
Scott, yes.
Your question, and it might dovetail into the solutions thing, is what barriers are there to asking the providers to actually seek a higher level of certification? Because, because we are running into these things, to me, it would be nice to be able to go up to rather than have this lower ceiling on things. And I mean, I'm happy, and I think a lot of people in this meeting would be happy to go and talk and support for a higher level of support for the providers, knowing that there's a higher level of care available. But then, and getting, I don't know if that means that we need more MDs on site or whatever it is, but I think I would like to know, I guess, is that something that these groups who are providing the service would be willing to explore, properly supported?
That's a great question, Scott. And who from our providers or health department want to speak briefly to what it would take to up the licensure? Perry?
Super quickly, and obviously way more detail and information. What Scott is actually referring to, and I think that Amy Pereira and others can probably speak to this as well on the mental health triage side, is really what's referred to as an ENT, or an evaluation and treatment facility. That is an involuntary facility. If I recall geographically, the closest one was in Everett, but that's not open right now. The Mukilteo, there's a ENT in Mukilteo, obviously within our North Sound region, but it's not just a level of certification licensure, to my knowledge. It's also building design. It is certainly staffing model and et cetera, but the building, the Ann Deacon Center for Hope, was designed as an involuntary facility. I have some thoughts and comments about, sort of earlier stuff of where IPRTF was expecting involuntary. I respectfully disagree with. I was actually a part of those discussions as well. But at any rate, it is really twofold. It is staffing, as Scott made reference to, and it is also building design to reach that level of care, such as an evaluation and treatment center. So I'll stop.
Perry, to clarify, you just said that the building was designed for involuntary. Did you mean to say that?
I'm sorry. The building was designed for voluntary. Thank you, Melora. There was absolutely discussions around involuntary components and so forth, but we can get into that with the solutions piece as well. Thanks for the clarification, Melora.
Great. Okay. Let's see. Mike Hilly. I can't see him, but I hear that Dean White has a question, and then Arlene, and then we'll stop there. Take just a few more minutes for towards solutions, and then we're going to have to move on with the schedule. So let's see. Go ahead, Dean.
Actually, Perry addressed what I was talking about. I was in this. He was, and there was thorough discussion about whether it could be an ITA facility or not. And I don't think the sheriff and other law enforcement folks were happy with the decision that it not be, but that was thoroughly discussed.
Mike Hilly, please.
Yeah, thank you. Good morning. I appreciate the conversation. Mike Hilly, EMS manager for Whatcom County. And just a couple of items, and Scott spoke to this just briefly related to the certifications, which is EMS has certifications they have to tend to as well. So the EMTs and the paramedics, their medical practice is determined by the county medical program director. Ultimately, the state medical program directors design the type of protocols they can operate under. And this particular conflict even came up at the state level last week, which is a medical program director be very comfortable with EMTs and paramedics doing alternate diversion, but they they always conflict with the facility. So we have not been able to divert anyone from the field into the center. Now, our community paramedics have been able to do that on occasion. And what you heard from Scott Rickman today was exactly the type of amount of time and energy it takes to do that. Our doctors are very comfortable creating diversion protocols for the facilities and want to do this in a big way. But yeah, it's super conflicting. And so somewhere and increasing the certification level may not solve that problem, but once they get to the facility, somebody else needs to sort out those details. One of the conflicts you heard earlier was medications. We tell our patients to leave their medications at home because if you take them to the hospital, they're going to lose them. They want a list. The hospital wants to deliver those medications. And so that's a small piece that we have to untangle with all this. And in addition, I was in on this 8 years ago. This has been that long conversation as well. We had deep discussions about that back door. And I felt like I kind of lost lost on that avenue because the idea was that, number one, it didn't need to look like you were going in the back door of a facility in some sneaky way. It needed some type of covering over it with ample lighting in the back so that when the rig is sitting out there in the snow and the rain and it takes a while to answer that door, you're not out in the cold and rain. And then once they went into the facility, there would be somebody that would check them in and determine whether they needed the mental health more as a priority or the SUD as a priority at that moment. And so we just haven't achieved that. And on the back of the works of our good community paramedics have been trying to navigate. I think there's a sweet spot in there somewhere and where we can get to that. But right now, I'll say our Whatcom County Fire Chiefs Association doesn't have a confidence in this facility. And therefore, we have not been able to push out protocols for EMTs and paramedics for diversion from the field in front of all this. So, once again, thanks for the conversation. I'm hoping for solutions as well.
Mike, thank you for that. And Arlene, do you have a quick comment you'd like to make?
Yes. Because the facilities like Pioneer and Compass Health pay the lowest salaries, at least they did in the past. If you pay people correct salaries, then you get the staff who have good judgment to make a personal decision about something, even if it breaks rules. So I think it's very important that staff get a proper salary because you'll get better people, and better people make better decisions.
Okay, thank you, Arlene. Let's move on. Let's see. Let me do a time check. We have 9 more minutes. It sounds like we have surfaced a lot of the barriers and the kind of systemic problems on the medium and high levels. And I think there's some low-hanging fruit where we could circle back to and make some changes. And it does sound like our partners in service, our service provider partners here, are already working on some of those things. Let's run back to, let's see, Melora, and then Shannon, if you can hit some kind of top level things, that would be great. And then I will, and Renee, I see you, will get to you, and then I can, we'll somehow produce notes from this meeting, and I promise you we will work forward from there. So I will be tracking that. So Melora, you go first.
Great, thanks. I'll try to be brief. I just wanted to also recognize the ongoing communication that we try to have as a community with specific incidents. So I'm sure you're all aware that our providers use a crisis stabilization feedback form. So when something happens that either went really, really well or didn't go the way that the provider had hoped, they're able to give real-time feedback. And then we get that at Health and Community Services and then work directly with the providers and the person that wrote it to problem solve in real time. And then in our monthly oversight meeting, we review those as a group, and most everyone that is on this call, we have representatives there. Sometimes law enforcement isn't able to join those meetings because of schedules, but we do have an ongoing monthly meeting where we're trying to problem solve in real time. I would also say some takeaways that I have of just working well with Pioneer and Compass are the goal to open the lobby, to provide adequate transportation for an individual when they're not able to get in, to address any staffing shortages that the Medicaid reimbursement and of course crisis services that come through the state and the BHASO are not able to pay for. So is there a role for the county to supplement and support the providers in that way? So a lot of these conversations are happening. And I want folks to be aware of that. And I don't know if other providers on the call can speak to if they think those efforts like the feedback form or the monthly meeting are not effective, but I think we are, right? There's so many complex details that we just want to keep at this and keep turning up the heat on what we can do and what we can control locally, as opposed to the ITA issues that we have within the state. Even if this facility became involuntary, we're not addressing what happens around ITAs. So, I also want to speak to how many people are receiving quality services there at the same time that we're
Very
trying
good.
to problem solve
Thank you
this.
so much, Melora. I really appreciate that point of view. And Renee, do you have your hand up? Did you want to speak?
I was just gonna say what Melora said regarding a lot of these things we've already been in contact with and having conversations around these changes. So
Yes, I really hope that nobody on this call thinks that we don't think these conversations are being had and that there's any ill will here or anything. I think it's important for our behavioral health committee and policymakers to be able to hear all of this, all of the issues and who's doing what and where we need to go next. We are designing a 23-hour crisis relief center soon, and it's going to need to dovetail with this. What can we do? We're in the middle of a crisis. Let's do the best we can with the resources we have for the for service delivery for the end user, who are people in who have great need. So Perry, with that, do you have a comment?
Just super quick. I just really appreciate the comments that folks have made up to this point in time. And as Melora had made reference, we have a monthly Crisis Stabilization Center Advisory Committee, and many of the individuals that are here are actually a part of that meeting, as well as law enforcement, the hospital, providers, of course, and et cetera. And I think as a result of that, in that communication, we actually had law enforcement drop off, and I'm going to combine the two sides of the services. In 2022, we had 55 individuals that were dropped off by law enforcement. And that actually, through the work, I think, in the Crisis Stabilization Center and Communication, it had basically doubled in 2023. So we're on a great trajectory, I think, as well. Obviously, the challenges are there, but I did want to bring that piece to it as well. So
thank you very much, Perry. Dan, and then Shannon.
Yeah, there's not a hand up from Judge Lev, but I did want to seek the judge's input as it relates to the judicial branch of government as it relates to the topics that we're discussing, if you're so inclined.
Excellent. Judge Lev.
Good morning. We're trying to address these problems. We right now have a therapeutic court that's been in operation, if you're not already aware, our mental health court in conjunction with the county. So we have those individuals that have diagnosed mental health conditions participate in that. It's been very successful, and just had a graduation the end of January for an individual who was very involved with the criminal justice system, and law enforcement was very familiar with this individual who in the 2-year program turned things completely around and graduated and had all the charges dismissed. We're currently putting together our community court, which hopefully will pick up with those individuals who don't have a diagnosed health condition, but certainly need services. And we have just recently hired on our therapeutic courts manager who's with me, and we're putting together all of what needs to be put together to have that have a soft launch, hopefully with grant funding and the assistance of the city of Bellingham. We'll have an avenue by which some of these people in desperate need can and have criminal charges can come through and have an alternative court situation with all of your help. So that's what I have to say. Thank you.
Great. Thank you. You know, Shannon, I think I would like to circle back with you off this call and distribute your thoughts and ideas to everybody on this call separately. So because big solutions are going to take more time than we properly have to give them air. So I would like to thank everybody for participating in this conversation. I think it's been important and very helpful to me, and I'm sure to other members of the Behavioral Health Committee. And now I would like to move on to the next item. Dan, is that all right to move on to that? And then we have public comment, I believe.
Yeah, we need to accommodate for public comment. We do have, I think, 6 attendees still in the wait or in the on the call, and it's 10:19, so we need to be a little bit concise. We should probably allow for, I don't know, 4 or 5 minutes for public comment at the end.
Okay, well, I'm going to keep this really short then. And the folks that you are all welcome to hear the rest of this agenda. But if you drop off, thank you so much for taking the time out of your day and attending this meeting. We really, really appreciate it. And with that, I'm giving a report on the Justice Project implementation plan, kind of an execution update. So there's enough good stuff happening that I cannot report on all of it in 4 minutes, but I will tell you a little bit about the report that I sent out. And so I interviewed Tyler Schroeder and Kayla from the county executive's office, and we spent a good hour and a half going through everything that the county is doing to execute on the implementation plan, what the county said they were going to be doing in year 1. So I am pretty pleased with where things are, but there are various gaps and opportunities, especially for the IPRTF, to participate and help. So I'm going to read you just a little summary that I've got here. The county is making good early progress, getting the ball rolling on these critical projects. The executive's office and other departmental staff have plans and intentions for nearly all the areas listed in the implementation plan as action starting year 1. I am concerned we do not have the project management personnel to make as much progress as we need in the near term, however, given the extent of the problems we face. Complicating our need for progress is the impending loss of Tyler Schroeder, who has been the architect and project manager of the county's response in these areas. The transition shouldn't mean, or cannot mean, a slowing of progress and action. The IPRTF has the opportunity to provide great leadership, wisdom, and action regarding the implementation plan. Ultimately, it needs to ensure the counties, the service providers, and the partners' resources and efforts are expended within a well-conceived structural model of best practices and rapid feedback loops to ensure improvement and course correction as needed. The IPRTF can help us better understand the end user, the justice-involved people, and their needs, and reshape systems around them to better provide services, incentives, and accountability towards healthier outcomes and a more just community for all of us. So please go through the report, and there are links to the implementation plan. You can check out in more detail what's in there, and there's a link to the ordinance as well. But I have stated very quickly and clearly what the county has already rolling, and then I've made some observations from my own point of view of various gaps we have and a variety of opportunities. And it's my hope that IPRTF and its committees can really move things forward, and I think we have a great opportunity to do so. So we have just a couple minutes for any questions regarding this, and then we're going to go to public comment.
Committee questions, feedback, Mr. Parker?
Yes, Courtney.
I was just curious, did I miss if someone from Peace Health was in this conversation? Anyone from the hospital attend?
No, but that would have been good.
Yeah, I think so.
They're the biggest referrer by far to the Ann Deacon Center. And I think it's worked out pretty well for Peace Health, as far as I can tell. It would be interesting.
I'm going to call on my co-chair, Mike Parker.
Yeah, no, I really appreciate the conversation, Peter. I appreciate the cover, obviously the report and all that work that was done by the stakeholder advisory group, and all of those projects are really wonderful to hear. I want to cycle briefly, Dan, thanks for calling on me. I just want to cycle back to our conversation, and the observation was made. We have talked about this many times, and I want to thank Peter Frazier for kind of guesting, taking us through this today, so Dan and I could be more participants. I think as co-chair, sometimes you don't always get to be a participant. So Peter, we thank you for leading us through this, and I really want this to end up, and hopefully the rest of us do too, in a proactive kind of problem solving. The one thing I didn't hear today mentioned is learning from this, so we know as we go into building future facilities, what process do we need to do? And we've heard from Dean that some of those discussions happened, and yet we still had a lot of confusion. So I think as we go forward into new processes together, right, in whatever role the task force has and what law enforcement has and our architects at the county, working together really, really consummately and cohesively and integrated, so that our final products end up where everybody is happy and understands what they all are. I just want to thank everybody for putting their heart into it. And that's one thing I got today as a co-chair, is just sitting and listening to the amazing heart that came from all aspects. Dan, thank you for calling on me, and I'll go ahead and pass it back to you.
Okay, it's 10:25 right now. Jill Nixon, do we have anybody in the attendee group that has their hands up?
We do have a number of attendees. If any of you would like to speak to the committee, please virtually raise your hand now by selecting the raise hand icon. No hands are raised. Thank you.
Okay, thank you. Peter, you've got a few more minutes here, if we are, and to the committee, if there are questions, we've got about 5 minutes here to ask them. So committee, do we have questions or guests that are at the committee here today? Dr. Boosted, did you have your hand up?
Yeah, if I can just take a couple of minutes, I have like a couple of thoughts. One would be, as I mentioned, helping the people who are actually actively engaged in treatment and are not there only from law enforcement may help break the stream so that they're not engaging with law enforcement. And so what I mean by that is actually maybe helping people have a ride from detox to a local service provider for medication for opioid use disorder, for example. So a lot of places like Ideal Options has same-day visits. My team can do pretty well with getting people in rapidly to continue the medications that are the prescriptions that are often given when people leave detox. I just think that space is the best place to coordinate all the services that we have. Like that connection will help so that people don't get involved in these revolving door situations. I'm thinking, for medications, helping people who are unhoused and have low resources get, taking them to pick up the prescription, for example, something like that. Rapid coordination with, case management groups upon discharge or discharge planning before they leave. I know that case management at facilities like detoxes are really hard to do financially in many cases. As far as medical services, I was thinking about other things that we can do, such as having, it'd be cheaper, instead of having a doctor there, to have nurses that are already engaged perhaps work on a telehealth basis with medical providers to kind of determine, like, do a triage if someone really does need to see it, go to the hospital, or if they could just, hey, let's call a local pharmacy, let's get them this prescription for this or that. I can review the records. I'm not saying I can do it because I don't have the bandwidth to do that, but I think that like something like that might be a reasonable kind of midway option. So those are kind of the few things that I had that I want to take some time with.
Okay, appreciate that. And just wrapping up here in the last couple of minutes during our meeting here, the next meeting with the Behavioral Health Subcommittee will be a joint meeting with Legal and Justice Systems in March. And I would encourage folks that are on this call to attend that. And you can contact Jill Nixon for the Zoom link to get that going. I see Dean White's hand up. Go ahead, Dean.
Yeah, I just didn't want to miss the opportunity to point out the intersection between the first part of your meeting and the implementation plan for the Justice Project. I really would encourage you to take a hard look at the uses of the proposed behavioral care center portion of the jail and its role in terms of involuntary holding of people who are also committing multiple misdemeanors. Just don't lose that opportunity. It's an important intersection.
Okay, thank you, Dean. Courtney, go ahead. We've got like just about a minute and a half here. Go ahead.
I'll keep it quick, but yeah, I really want to highlight what Rob just said. And the way ITA is being used or not being used by the jail is very interesting.
Okay. Thanks, Courtney. Thanks, Dean. We just got about a minute left here. I think that Co-Chair Parker, I think that we need to continue this discussion and take it to a different level at the Legal and Justice Systems meeting to look for intersections between that group's activities and their policy priorities and this group's priorities. So we'll have a discussion offline. I wanted to thank everybody here today for attending. This was a big discussion. And it's not over, but we have a lot of work to do. So I just wanted to acknowledge your participation and the work that everyone does from their various sectors. And let's not stay in our silos. Let's connect and let's make sure that we continue these conversations. And we'll be talking soon. And with that, I'm going to go ahead and adjourn the meeting. It's now 10:30. Thanks everyone for coming today, and we'll talk soon. This meeting is now adjourned. Thank you.